let's get this show on the road. So, thanks everybody. Thank you for coming out. This is a show of your support for Porter. And what I've learned in my 5 months is that we value our services here in Addison County. And whether it's healthcare services or services for the elderly or the children or those with mental illness, we value and protect and work hard for the services we have here. So I appreciate you coming out tonight. The second thing I want to say is this is your time. So we are here. I'm here. We have a number of board members, Bill Townsend, Steve Terry, who chairs our Legacy Committee, Maureen McLaughlin, our board chair, Linda Schiffer, Judd Bartlett. And so, I have some information that I'd like to share with you, but we would love to hear from you, both questions and comments, opinions, thoughts. So please feel free to stop me anytime and ask questions or comment on what we're talking about. The topic tonight is what we call our legacy project. And basically, we're using the term legacy to mean what do we want to leave for those who come after us? What do we want to leave for those who come after us? And the short answer is the best Porter possible. The greatest depth and breadth of services, the greatest quality and quantity of services. So we're trying to figure out how to position Porter. We've been here for 91 years. How do we position Porter strategically so that we have the best future possible? And I come to break this down into two pieces. Number one, what do we want to be? And to that point, we've been out talking to the community and asking, what do you want us to be? And we've heard a lot of different things, but the major theme is we want you to be there. And we've come to call that access. And basically, the message we've gotten loud and clear is, please be here for us. Please make sure there's a doctor in the office and make sure there's a hospital on South Street to take care of me when I'm sick or injured. So that is the message we have gotten loud and clear. And, in addition, everyone seems to think it'd be a good idea if we're better, but certainly do not become diminished. So we've heard that, and that is our goal, to be here for the long haul, doctors in offices, hospital on South Street, as good or better than we are now. The second part of this issue is, how do we achieve that goal? And that's what we've been talking about. We would be my leadership team and our board of directors. And it's really come down to, will we achieve that goal on our own? Are we best off taking a path of independence, or will we be better positioned if we partner with a partner? And so that's what we're going to talk about tonight. And I'm going to talk about some timelines and some the general road forward. I'm going to talk about who the potential partners are, who the preferred partner is and why, and some generalities about the University of Vermont Health Network. And then I will get into some specific bullet points, some specific points that we were talking to UVM about as part of our conversation. Sound good? Okay? All right? You with me? All right, let's do it. Okay. Some of you may have seen this slide. A couple points here. We started this project back in 2014. So I didn't whip this thing up last spring. It's been ongoing. I'm the third chief executive to oversee this project. It really heated up this winter into spring, and a lot of work has taken place in the last 8 months. We have a subcommittee of the board called the Legacy Committee. We've been doing a lot of community outreach. And this spring and summer, we did what's called an RFP process, and that stands for a request for proposal. And basically, we wrote a letter that says, we are Porter Hospital. We're a 25-bed critical access hospital in Middlebury, Vermont. We have 12 office practices. We offer these services. We want to be around for the long haul and provide quality service for our community. We want access. We want integration. We want financial stability. Do you have any interest in us? What do you have to offer? So we sent that proposal out to a number of potential partners, and results came back, and we've been sorting through those, and I'm going to talk about those as we go forward. We did some general forums early in the summer. Now we're getting down to more specifics. At some point in the next few months, a decision needs to get made. So we've made one decision. The decision that has been made is that if we choose to partner, the University of Vermont Health Network is the preferred partner. So the decision is, if we partner, that's who we go with. The decision that has not yet been made is, should we partner? That decision is ahead of us. The reason we sliced and diced this decision is that we couldn't go out and talk to our stakeholders about anything, any level of detail, unless we whittle it down to one partner. When we had 2 or 3 partners in the running, they all said, no, we're really not comfortable. You can't talk about the details of a potential deal if there's 3 of us in the running. So we had to decide who is the preferred partner, and now we will make the second decision of, should we partner? Does that make sense? Okay. So upcoming is the decision, and one path would be independence, and we would decide we think we can be the best porter possible, taking the path of independence. If that's the case, then we get to work doing the hard work of making this place as successful as it can be on our own. The other possible path would be that of partnering with the UVM Health Network. If we choose that path, we would then sign a non-binding letter of intent. So it's non-binding, and it expresses intent. And the intent is to spend time, probably 3 to 6 months, doing due diligence and basically negotiating, working with UVM to see if we can come to terms that we all agree on. We probably would, but it's possible that we wouldn't. So the letter of intent, again, non-binding, it sets into process a more formal negotiation. Attached to that letter of intent would be something called a term sheet. And a term sheet is like an outline, a scaffolding, if you will. It's bullet points, issues, governance, CEO, employees, medical staff, medical office building, EMR, issues like that, with some wording underneath each issue that talks about what we've talked about and what we agree on. Doesn't go into a ton of detail, but has enough detail there that we've had some preliminary conversations around these, really important issues. Okay. If we were to sign a letter of intent and we would go into negotiations, at the end of that, we would either say, we can't do this, we just can't come to terms, or we would sign it's called a definitive agreement, and then we would be officially affiliated with the University of Vermont Health Network. Okay. So, going back in time, these are the folks we talked to, and it's a diverse group. Quorum is a for-profit healthcare company. They're based in Brentwood, Tennessee. They own about 40 hospitals nationwide, and they manage quite a larger number of hospitals. We sent them our request for proposal. They looked at what we were looking for. We looked at what services they offered, and it really was not a good match, and these conversations ended pretty quickly. We did communicate with Dartmouth. There's a relatively small segment of our patient population who go to Dartmouth, and they love it. I've never been a patient there. I hear great things about it. Unfortunately, it's just we're too far. We're in the wrong direction. They're expanding to the south and east, and we're to the north and west. We're right in UVM's backyard. It became clear this was not going to work. This is the third option that we really pursued fairly far down the road. We looked at a fairly loose affiliation with the hospital, and then they have a number of practices that are set up in a separate structure, and we looked at, could we move some of our practices into their practice structure? And at the end of the day, you know, Rutland is a good place, and I think it's on the up and up and getting better. But at the end of the day, we're a small community hospital. They're a big community hospital. There's a lot of overlap in what we have. The value just wasn't there. And so again, we were talking with UVM throughout this. You know, I should say these talks, they've been really productive and professional and open, and we think there's significant value here. And so I'm going to talk more about that. Before I get to the specifics, I just want to talk about the generalities of why this might make sense. First of all, we share a mission. I have the mission statements here. They're very similar. When you think of our mission is to care for our community here in Addison County. UVM really has a dual mission. Their mission is to care for their community in Chittenden County, which is a big community. You know, the biggest community in the state of Vermont, one of the few communities that's growing, so that keeps them pretty busy. The other part of their mission is providing tertiary care, so providing care for all the sickest patients, and they'll do that from, you know, central North Vermont over into the Adirondacks, so that's a pretty big piece of work as well. So my point is, we have similar missions, but they're not overlapping missions. You know, we want to care for our community. UVM wants us to care for our community. They don't want to care for our community. They have their community care for and tertiary care to provide. So, you know, one concern has always been, do they want to line up with us and take all our business away? And the message I've been getting for a number of years, and I'm coming to believe, is that they really want us to care for our patients here, as we do. And they want to be there to take care of our sickest patients who we can't care for here. We share patients. So we have zip code data that shows about half of all of our patients get some portion of their care at UVM, which is a big chunk. And, you know, those patients are going up and down Route 7. And maybe they're getting their primary care here and some specialty care there, or vice versa. But as you all know, as patients, we do not share an electronic health record. So when you go to UVM or Dartmouth or Rutland, they're starting from scratch. They're picking up the phone, they're calling medical records at Porter, faxing things, which is exactly what I do in the ER when I have a patient who comes to the ER who just left Fletcher Allen or UVM 2 days ago after a week-long hospital stay. I pick up the phone and call medical records and they fax me things. So there's this sharing, this sort of natural clinical affiliation, if you will, of patients going north and south who would benefit from a more integrated approach. We share culture. I really put this in here for the medical staff. About half of our medical staff did some part of their education or training at UVM. I did my residency there. So again, we're used to referring there. We have colleagues there. A lot of us train there. And as I said, both of us share a goal of caring for our own communities. And our mission statement and their mission statement, pretty close. Okay, so now it's time for specifics. So questions so far on the general things I've been talking about? Okay, yes?
What you've been saying, you haven't said anything, and maybe it's later in the presentation.
Yes.
Where does staffing come in?
Yeah.
Are you unfortunately going to lose staff?
Okay, great question. So also I was, yeah. Yep, so I was asked by my media friends to ask, when people ask questions, ask their names. Can I ask your name?
Oh, I'm Bonnie Campbell from Shore.
Hi, Bonnie. And so the question is staff cuts. Great question. Great question. So when I talk to the community, what I hear is make sure we have access. When I talk to our employees, which I do a lot, I hear make sure we have jobs. And that's normal and appropriate. So basically, In terms of our employees, they stay our employees, except for the providers, which I'll talk about separately. But, you know, of our 800 some odd employees, 60 some odd are providers. All the rest of them stay Porter employees. You know, what I'm telling them are a couple things. Number one, their wages and benefits won't change. Now, when I say that, I qualify with they won't change any more than they would if we stay independent, if you see what I mean. I mean, all of us have to be prepared for wage and benefit changes, but there won't be any material impact caused by an affiliation. Mm-hmm. You know, secondly, the issue of job security. You know, what's best for everyone's job security is for Porter to be as robust as possible. So, in other words, for us to be as busy as possible, see as many patients, provide as much care. It's a win-win. It's a win for the community, it's a win for the employees, it's a win for Porter. So whichever path, either independence or affiliation, creates the most robust Porter is best for the jobs. You know, we're looking to Central Vermont Hospital. It's in Barre Montpelier as a model. They affiliated with UVM 5 or 6 years ago. They're busier than they used to be. They have not laid off employees. You know, and you know, the other thing I tell people is, again, UVM does not have, for all of our employees who do work, physical work or caring for patients, they don't have the staff to send down here. So nurses, providers, all the housekeepers, dietary folks, you know, certainly their jobs are secure. You know, there are probably a few areas where you could imagine there might be some efficiencies, and yet other places that have gone through this process, that has not been an area of big savings. And so I'm telling people, not, you know, within the realm of predictability, that their jobs are relatively secure. Yeah. Okay, specifics here. So this is just a legal term. That's what the relationship would be called. Governance. You know, as we go through these specifics, I mean, the general theme here is there are things that Porter could get through a partnership with UVM. You know, real material goods. And then there are things we need to give up. And in the world of giving up, it's basically some power. You know, right now, we are an independent organization. We make our own decisions. The board hires me. We create our own budget. We run it through the board. We take it to the Green Mountain Care Board. That's it. We would give some of that up, and I'm going to talk about that a bit. We would keep our board of directors, but there would be a parent board who is above our board. And we would have a member on their board, and they would have a member on our board. They would have input on the selection of the CEO. So, you know, it would be a joint recruit, but UVM Health Network would have some input there. This issue of core services is a hot button. So we really want to preserve everything we have, all the services that we currently provide, and preferably we'd like to add more. So these are the services we have in very general terms, and we have given this list of services to the University of Vermont and said, this is what we expect to do, and they have said, that looks like a reasonable and appropriate list of things you should do at a community hospital. So at this point, we're in agreement that this makes sense for Porter. This is what we want to do. They will support us in providing these services. You know, the area of agreement that we would want to focus on from here is you know, how much control we have long term. And you know, can we count on doing these things 5 years from now, 10 years from now, 20 years from now? And so we're going to work to get the best terms that we possibly can. Again, I think going back to basic principles, being the best Porter we can, providing the best services, the highest quality, the easiest access, and making these services all busy is our ticket to success, whether we're independent or partnered. And if we're busy and patients want our services, we're going to succeed whichever path we choose. Does that look like the right list?
Where's oncology?
You know, so oncology is not on here, and that's a great question. And we had that question before, and we talked about adding it. You know, right now, Porter Medical Center actually does not offer oncology. In other words, although we actually don't offer urology either. Urology right now is offered by UVM. Dr. Mahoney is employed by UVM. Mm-hmm. So oncology is currently provided by Dr. Unger and Dr. Nunnick. Dr. Unger being self-employed, Dr. Nunnick being employed by UVM. And it's clear to us we have got to maintain oncology services in our service area. And so we need this on the list. But yes, we are committed to having oncology here. Tim?
You don't have pulmonary.
No, we don't.
No, I'm talking about respiratory therapy, not
Yep.
pulmonary.
That's a good point. Can we add those, Ron? Yep. You know, and I've talked to some folks. We've talked about palliative care. That's something we'd like to get back in our community. You know, the services we'd like to add, things like neurology. You know, we have some dermatology now. We've been trying to get more dermatology. Spine, you know, some sort of services for people with back pain and who might need spine surgery. That would be a nice thing to have in our community. Okay. Our employees stay our employees. You know, we currently have a quality department of 3 people. They work very hard and help us maintain quality services. The UVM Health Network has what's called the Jefford Center. It's grant funded. They have 35 employees. It's a great place. A number of us have been up there to see the resources they have available, and that's something that we would take advantage of in a partnership. This just talks about, you know, again, we would continue to provide what we do now locally and try and work with UVM to augment our services. In the world of finance, this is what I call the free lunch. In terms of, these are savings that are relatively invisible. If you sign on with a partner as big as UVM, you get better bond rates. You get cheaper insurance. You get some of your risk management and legal services at discount. You know, these don't require any staff cuts or anyone to work any harder. So this is typically in the range of 5%. We've been planning on maybe it's 2 or 3%, but this could be as much as you know, $1 or $2 million a year for our margin. So this is attractive. This is a big deal. Again, our budget, we create it, our board approves it. It will now need approval by the by the UVM Health Network, and that does, you know, when they control the purse strings, you give up some power for sure. This is a big deal, the electronic health record. We use a platform called Meditech. It's actually one of the more popular EHRs used in the United States. With that said, it's a bit of a workhorse. I describe it as clunky. Some of my colleagues call it worse things. And you know, UVM has Epic. Epic is becoming the preferred platform. They use it at Mass General, Johns Hopkins, UCLA, Yale, and this would be part of any deal with UVM Health Network. One, we'd get a better EHR, but 2, we would have an electronic record that is integrated with UVM. So if you're a patient that gets services at both places, you would move across the organization as if you're a patient of the system, not 2 separate places.
And doctors that have free access no matter where they work.
Right. Yes.
Under the budget, so UVM would have say over the budget.
Right.
When you go to the Green Mountain Care Board,
Yep.
would Porter then go as part of UVM, or would it have to go independently like it does now?
No, actually, if you, when the video comes out in a few days of the hearing that took place last week, CVMC sat simultaneous at the table with UVM, and Dr. Bromstead actually led the presentation for the system with the respective CEO and CFO of CVMC at the table as well, but it was all as one. I would envision that the CEO and CFO of Porter would similarly flank Dr. Bromstead for one presentation.
Yeah. Yes, Max Kraus. And that was Tim Cook, sorry.
If you go forward, have you done
Yeah.
the arithmetic to see that under these circumstances,
Yeah.
you can predict that Porter would emerge from its present financial problems and become profitable?
Yes, we're getting there.
Okay, thank you.
Yeah, my last two slides are financial models. So this is a big deal, and this has been a big deal for me since I started in this position and first talked to Dr. Bromstead about this months ago. That, you know, from a clinical point of view, this is a game changer. To have an EMR that's integrated with your local tertiary care center is just so powerful that it means a lot to the clinical folks. I think it'll mean a lot to the patients. So currently, we own 4 practices in downtown Middlebury, and they're scattered throughout the town. They're not on campus. We lease the space for $400,000 a year. That's for the 4 practices. You know, 2 of our busiest practices, Addison Family Medicine and Middlebury Pediatrics, have no radiology services. So if you're there and seeing your doctor and need an x-ray, you got to get in your car, drive through the traffic in town, come over and get an x-ray. So, you know, what would be really nice for our patients would be to have a centrally located, multi-specialty medical office building that offered primary care, specialty care, you know, specialists from Burlington could come down. It's a project we've talked about for over a decade. We've never been able to get there. We're not able to get there right now. Looking at the path of independence, it would take us a while to get there. So we are talking to UVM about this, and it's another, I was telling Fred on the way in, another, you know, big issue that I feel strongly about, that this is something we really need. And when I talked to Dr. Bromstead and said, look, you know, we really need a medical office building here, he said, yeah, that's the kind of thing we do with our partners. So we have not agreed on scope, how big, how many dollars, how many square feet, but we're having this conversation about this being a need for our community. It would create efficiencies for Porter and great efficiencies for our patients. And this bullet's for the providers, the doctors, the PAs, the nurse practitioners. So as opposed to all of our other employees who stay employed by Porter Medical Center, our providers would eventually move over to the UVM Medical Group. And I've talked to the providers about this, and we're in the process of trying to learn more. We're going to set up some meetings where we have physicians come from Barry Montpelier, Central Vermont Hospital, and from UVM, and tell us what it's like to work for the UVM Health Network. It's actually the largest physician group in the state of Vermont. They have over 600 physicians. It's run by physicians. Their CEO is a physician. So, you know, this is something that we need to learn more about. It makes our medical staff a little apprehensive, understandably, that they would change employment. You know, with that said, they want to learn more. They have colleagues who work for UVM, and they know that they're getting by just fine. So we're not expecting this to create huge problems, but it's an issue that we need to learn more about. Yes, sir. What's your name?
Nixon.
Bob Nixon. Yep.
Does that mean that if I was going to a doctor and I was very happy with him,
Yes.
in 18 months, UVM could decide they want to transfer, they think that's a superstar
Yep.
doctor, we're going to bring him up to UVM, we're
Yep.
going to send someone else down to Middlebury. Is that a possibility?
remote to no. I'm going to say remote to no. So the basic message we're getting from UVM, and I've gotten this message for years, is primary care is your business. Your business being Porter. So if you're talking about your primary care doc, for instance, they're not going to move that person. Specialty care, UVM does have some more interest, but I can't see them pulling anyone out of our community. Yes, sir.
What is the advantage
To who?
to the community
Of
of not having a reinsurance that the providers we have are guaranteed to be staying
okay.
would not be pulled out and brought up to Burlington?
Yep. So
Can I take a stab at that, Fred?
please.
Steve
Yep.
Kohler, Vice President of Medical Staff, and I'm on the board as an ex officio member because of that position. I think there will be probably a substructure that stays down here. A lot of the governance will stay down at Porter. A lot of the governance stays intact. A lot of pretty much the entire administrative mechanism stays intact. And there will probably still be a Porter entity that's a subset of UVM Medical Group. There's a little bit of a difference in the way they treat primary care and specialty care, but as far as the opposite of a brain drain, I think we're going to have a lot easier time recruiting and retaining under these circumstances. They've got a robust a residency program there, a medical school which I attended. A lot of folks here attended medical school up there. And this will be a good conduit to get people down here. And I think there are conditions of employment with the UVM Medical Group that are favorable and that make employment by that group beneficial. I am not employed by Porter, but my partner and I are looking at joining the UVM Medical Group simply because it's a good place to work. So I think it's going to be a net benefit for everybody.
Yeah. I think it's unlikely that, it's hard for me to imagine a scenario where they would pull a provider out of our community. Is it impossible? No, but it just seems very, very unlikely. Fred Green.
Fred Greenman. Would the reverse be possible too, if you want a primary care physician and if you're willing to travel for that primary care physician because you have a relationship with my family?
Right.
You could go there, couldn't you?
Well, you can go, right now,
And then grow the primary care.
right now, if you want to see a primary care provider in the Burlington area, for instance, you can do that. The advantage of being an affiliate would be if you went up there and you see a primary care provider who's part of the UVM Health Network, and then, you trip and fall and wind up in my shop, I'll have your full medical record. So there really won't be, certainly won't be any barriers to going to Burlington or to Dartmouth for that matter. But, we'll share a common record. Does that answer the question?
Also share common, the budgets of each would be a little different, but it's not taking away business from. Right.
It will change things, from the way we see it. Right now we compete. And, it's not a ruthless competition with UVM or Rutland or Dartmouth, but we do compete on some level. And if we were part of the UVM system, that competition would go away. So right now, we're incentivized to keep patients here, and they're incentivized financially to pull patients away from us. That goes away. $1 paid here at Porter is the same as $1 paid at UVM. So it just takes the money out of the mix and, makes things like, where's the best quality? That's what should drive where you should get your medical care. Where's the most convenient for you and your family? What's the best value? That's how we should drive our decisions on where people get their care. Max.
Max Krause again. We have friends who couldn't be here tonight that live down near Brandon.
Yes.
And are feeling rather badly and left out that there have been no meetings at that end of the county.
Yep.
And I'm sure if they were here, they'd ask, what happens to the Brandon office? Are you going to abandon the lower part of Addison County?
I'm laughing. Dr. Wolfman's behind you. That's Dr. Carrie Wolfman, who anchors
Carrie, I know very well.
anchors the practice, our Neshabe practice in Brandon, and I think you spoke up loud enough for everyone to hear. So no, you know, in terms of primary care, I mean, our goal is really what UVM wants us to do, and what we want to do is make sure we provide all the primary care that's needed for this community, period. I mean, that's, you know, they're not going to do that for us. Nobody's going to do that for us. That's our job. And so we're working hard to rebuild primary care here in downtown Middlebury. We plan on maintaining our Brandon office. We plan on maintaining our Virgins office and plan on maintaining our Bristol office as well. Yeah. Yes.
Can you talk about salaries not being affected?
Yeah. Yes.
So does a nurse at UVM
Yeah.
make the same salary as a nurse at Porter?
So I think, and again, I'm getting into a little bit more specifics than I am certain of, but my sense is our employees remain our employees and will be paid, you know, the day this thing is signed, the day after this thing is signed, if we go this road, their wages and benefits will be exactly what they were the day before we signed. So Steve, correct me if I'm wrong, I don't see that changing now.
Yeah, that's exactly right. We'll
Yeah.
maintain a compensation and grade system that we have currently in place that will be based on appropriate market rates for a community hospital. And they're an academic medical center, and their staff will be graded on an appropriate market-based system for an academic medical center. And I would expect that would remain for the foreseeable future.
Yes, sir.
Jeff Freebach, Middlebury. This comes back, picking up on this kind of a governance question.
Right.
UVM Health Center, or Health Network, what's its relationship to UVM?
Right.
And UVM then to the state? And are there particular risks or opportunities in
Right.
terms of Porter affiliating with UVM in a broader sense?
So the relationships at UVM are complicated. The UVM Medical Group is separate from the University of Vermont, which is separate from the University of Vermont Medical Center. So they're three separate entities. And, you know, UVM gets state funding, and I'm not sure the medical center really gets any significant state funding. But again, I'm a little bit out of my area of out of my expertise. I'm not sure there's significant opportunities there. I'm not sure there's a big risk there either. Yeah. Yeah, Hillary Hatch.
In the area of separate entities,
Yeah.
our little hospital across the lake in Tycon,
Yes.
Moses Leddington,
Yes.
has become a part of the
Right.
health network.
Right.
In order to do so, they had to sell their nursing home.
Yes.
So their nursing home is now owned by a large corporation based in New York City,
Yeah.
Post-Acute Partners.
Yeah.
It's a for-profit organization.
Yep.
And they own nursing homes and pediatric specialty, living settings, assisted living, let's see, healthcare transportation, pharmacy programs, and Medicare managed care plans.
Yes.
And these places are in New York, Pennsylvania, Massachusetts, Rhode Island. Is that, given the position of the
Right,
nursing home
right.
here,
Yep.
makes me think that that very same thing
Yep.
could well happen
Okay.
next door.
So let me talk about Helen Porter in general. So I'll start with the general, and then I'll move to the specifics. So Helen Porter is our long-term care facility. It's actually three businesses. There's the rehab business where people come, get rehabilitated, and go home. There's the long-term care residential where people go and they live forever. And there's our memory care unit. It's about 100 beds, the whole thing told. A couple things. Number one, we as an organization are committed to having long-term care in our community. We view it as a core service. You know, we want to take care of our entire community. cradle to grave. We have the most vulnerable residents of our community living over there, so we need to maintain it. You know, number two, it's tough to make money in the long-term care business, and in fact, it's tough just to break even. So our goal has always been to break even, and over the last 5 to 6 years, we've had increasingly larger losses each year, to where we're on track to lose about $2 million this year and budgeted to lose $2 million next year. You know, it's not sinking the ship, but it does put a strain on the organization. So getting down to specifics, we are in fact looking very closely at Helen Porter and how to maintain the high level of quality. We have a 5-star CMS quality rating. There's only 8 long-term care homes in the entire state of Vermont with that level of rating. It's very hard to achieve. How do we maintain the quality but turn the finances around? So we have talked with UVM. And I've had this conversation with Dr. Brumstead. He's in my office, and I said, the blue roof building over there outside my window, you know, we need to keep that. And his response is, yes, we need to keep that. There are needs within the network for memory care, residential care, and rehab. So we need to evaluate Helen Porter and figure out exactly what the needs are. Again, if we go independent, we need to figure out how to do this on our own. If we were to partner, we need to figure out how to do it with a partner and where it would fit within the network. And we're having those conversations. You know, in terms of divesting, you know, either finding a company to manage it or finding another company to own it, we are going to look at those options. You know, I would feel remiss not to turn every stone in terms of how to turn this around financially. I should say that's not really what we want to do. We would have to be presented with a very compelling case from another company to take that kind of action. We would much rather keep it in the family where we control it and can manage it and know that we can maintain the quality. But we do need to look at that kind of thing. So it'll get looked at, and we'll continue to communicate on that topic. But our goals are keep it in the portfolio, offer the service, keep the quality high, keep it in the family if we can, and but we need to figure out, we're really looking at right sizing, how many beds it should have, you know, having more rehab beds and less memory care beds, reconfiguring it, doing some actually capital investment to make more single rooms and put in air conditioning and, you know, make it a more successful part of our family. Yes?
I'm sorry, just kind of follow up?
Yeah.
The two primary concerns as a result are, this doesn't sound like a position in which you will be able to decide what to do. It sounds more that if the marriage is to be made, certain parts of the dowry will have to be dispensed with. Or, and the other concern is that if this is owned by another entity, that these Porter employees will no longer have the coverage of being guaranteed that they will remain as Porter employees, because they won't be.
Wait. So say that. Who?
If the nursing home is purchased by another entity, there is no guarantee that those people will get jobs.
Right. So hold on. Sorry. I don't know that much about what it would mean if it was purchased by another entity. I just don't know. But in our conversations with UVM, they have not said anything about, you need to sell that place. That is not the message I've been getting. My expectation is if we go the road of independence, we're going to work on our own to make it successful. And if we can't, we'll look at other options. And if we go with UVM, we're going to work with them to make it successful. And again, we need to look at all our options, but it's not really what we want to do. And I don't think it's really where we're going to go, but I can't promise that, obviously.
Right. Can you just talk to the opportunities that may occur through affiliation with UVM to help keep it sustainable?
Yeah, go ahead.
Sorry, Rob.
All right.
That's what I was going to say, is that I could imagine some of the issues are the fact that if the beds aren't filled,
Right.
that causes a serious problem with the finances, and so
Right.
The fact that if we were to affiliate with UVM, I could imagine that we would actually possibly get more
Right.
patients to
Yep.
use Helen Porter,
Right.
and therefore that would help the finances
Right.
and solve maybe some pipeline issues
Right.
that we have up at UVM.
Right, and we're trying to do that whichever path we take. And if we stay independent, we're going to work with UVM, we're having these conversations. You know, they have patients up there who need rehab. They have patients up there who need long-term placement. Some of them are in the UVM hospital, and they even, you know, they're Addison County residents. We want to move those people back home. So there's barriers to doing that, but we're working on it. I think if we are part of a system, those sorts of movements will happen more fluidly. And yeah, no, we're looking at the same thing on the inpatient side. On our med surg unit, it happens to be full today, but you know, our census goes from what it is right now, 25. You know, 2 or 3 weeks ago it was 8. You know, so we have these big swings in our census, and you know, when it's 8, if we can get a patient or 2 down from UVM who's done with their tertiary care, they live locally, they need a few more days in the hospital, let's bring them home, care for them here, get them home from here, or send them over for some rehab and then get them home. So those sorts of opportunities could make us stronger, potentially. Yeah.
If I could just add
Yes.
something to that, Fred. You know, I think over the last 6-8 months, we got a first-hand look at the kind of operation we would have to become to go it alone financially. And the kind of decisions that we have to make under the circumstances would be really hard and stressful, and I think, or stressed. And I think that no matter whether we affiliate or not, you know, improving the performance of the nursing homes is important for the organization. I think the likelihood of us doing something that keeps the nursing home in the organization in a partner situation is actually far greater than if we were alone and we have to make these really hard financial decisions where it all comes down to the bottom line. And we can't, you know, when the bottom line forces our hand when it comes to our mission in the community.
Yeah.
I mean, there's a strong feeling throughout the institution that nursing home is part of our mission in the community. Yeah. And we want to maintain it.
And I can also tell you, one second, Steve, I can tell you specifically, we're going to have a plan for Helen Porter before we sign a binding agreement. If we decide to go the road of partnership, sign a non-binding letter of intent, you know, we need a plan for Helen Porter this fall, and we're going to have that plan regardless. So I don't think it's going to be UVM pushing us, pushing it. Right. Yep, interesting, yep. Yes, Sherry Klink, Cornwall.
There are lessons to be learned by talking with the hospitals that have formed this partnership.
Right, yes.
Have you done that yet?
We have. I mean, it's happened on a lot of levels. You know, I've actually encouraged managers who were worried, just pick up the phone and, you know, our lab manager called their lab manager. A number of people at my level have reached out to their colleagues, and then UVM came and a number of these potential partners came and did presentations, and UVM brought the CEO from Central Vermont Hospital, and she spoke candidly about what it's like to be an affiliate and was positive. And we're going to do more of that. I mentioned at the med staff level, we're going to have a gathering of providers employed by UVM Health Network and get a sense of what that's like. Yes. Steve? Yeah.
Going back to Helen Porter for a moment,
Yeah.
I think it's helpful to note that UVM is already currently involved in a number of long-term facilities within their portfolio, and they're reassessing how to best optimize their use, and that through the affiliation, we would find value in that exercise. So I just thought that was helpful.
Yes. They currently have 5 long-term care facilities within their network. I want to say one of them is a joint operation venture with a for-profit company. They own half of it. The for-profit owns the other half. I think the other 4 are all independent, and they're looking at their needs through the system. Yeah. I think that's it for the bullet points, and the rest are, financials. Ready for financials? So, you know, Steve Champa, our CFO, and his finance team spent hours building financial models. And a couple things to say about models. First of all, the specific numbers are never going to be exact. You know, you're predicting the future. So you build in assumptions, and then you look at future predictions, and their real value is in their relative sense. They're close, but the real power of the models is how things look relative to other scenarios. We use the same assumptions for all of our modeling, with the exception of, well, tonight I have 3 models here. I have independence, and this is what I call independence kicking along. Doing like we've been doing, making incremental progress, trying to make things better each day, but nothing terribly dramatic. Independent with initiatives, that's getting more aggressive. That is really pushing change harder and faster. And for that model, we use these numbers. We would improve our performance by 857,000 in 17, 1.7 million in 18, and 2 million in 19, and then ongoing. You know, we have never executed at this level. So it's possible, but it makes me a little bit nervous to assume that we can. And I know it would be challenging. You know, these are the areas where we know we have opportunities, and we're going to work on these areas in 2017, regardless of what we do. We're working on the Porter Medical Group. We just talked about Helen Porter. We talked a little bit about stabilizing our inpatient census, you know, getting patients from UVM and or Dartmouth who are done with their tertiary care and want to get home. And this is a coding initiative. All the other assumptions were the same. And some of you may have seen these graphs, but I'll just explain. This is called the survival line, this red line. And that's how much money you need to make to pay your bills. And this is the sustainability line. This is paying your bills and replacing equipment that wears out. And this is the thrive line. This is where you want to be if you're financially healthy. And these blue bars is Porter's financial performance. And I don't know if you can see these very well, but that's 17, 18, 19, 20, and 21. So this first model is kicking along. And, you know, I've been consistent since day one in terms of our financial position. I have told people, you know, the good news is we are not going broke. We're here. We're going to be here tomorrow, next year, the year after that, and the year after that. The bad news is we're not thriving. You know, we're kind of treading water. We're getting by. And you can see, you know, we're here at the sustain line. You take that out a few years, we start to drop a little bit further below the sustain line. So we get by, but it's not robust. You know, we were planning to upgrade our electronic health record this year. We had to defer that project till next year. It just gets increasingly difficult to replace our equipment and keep up our facilities. Robin?
Fred, the low blue bar on the left, the top chart.
Yes.
What's that year?
That's 16.
That's where we are this year.
This is forecast 16, and
For this year.
this year, yep. And we think
And
that's.
so what you're
yep.
saying is that suddenly, next year, we're going to more than double what our crop.
Yeah.
So what's going to be different that's going to get us from that little bar to that big?
I'm so glad Steve's here.
Well, so the first is that 16 represents a forecast that we generated back in the spring. Before we do the budget, we do an official forecast. It's a very forensic, detailed forecast. And it's based on what we know at the time. And the first quarter of the current fiscal year was, dare I say, fairly dismal. And so the official forecast that we created was based on what seemed like very appropriate assumptions going back in February and March. I'm happy to report that actually I think 16 will outperform that bar a little, but this was also a year of considerable turnover and high temporary labor costs, and we're anticipating that we'll come out of that into 17 and see some improvements. So I think the real results for 16 will be better, and therefore the jump to 17 really won't be as steep.
And if we were to go
Yep.
back previous years, would
Yep.
the bars be about where they are for 16?
For 15, 14, and 13, they'd be a little higher. 12, of course, was the trough.
Okay.
Right, so I remember these graphs, yeah, it's a little up here, then 12's bad.
So this is still ambitious.
This, little bit,
Optimistic is what I would say, because
Yes.
that's without initiatives. That is-
Right.
That's
This is-
basic.
this is,
The top.
yeah, we should be able to do that.
We should.
We should.
How many bake sales will it take?
I don't know, how many do you want to do?
Don't forget the owner one.
Nice. What's that? How many bake sales? Nice.
Knit blankets from Helen Porter.
Ron, can you organize bake sales for us? Maureen.
I think your beginning point, though, was
Yeah.
important, that regardless of the specifics, they
Yeah.
all are based on the same
Right.
base assumptions, so that relative to each other is looking at the different,
Right.
3 different models.
Yep.
Okay.
So here, this is independents getting more aggressive with change. Those improvements that I showed in the last slide, financial improvements. So you see, we do start to get above the bar of sustainability, barely, still not to the thrive line. This is ambitious. And then this is the UVM model, and it sort of speaks for itself. And Steve, can you explain
Yeah, I was going to say,
how does that happen?
To know how to model that.
Well, so it goes back to the fundamental assumption that merger and acquisition activity has typically produced a 5% savings. There's historical data from other transactions that prove that, and we only use 2.5% from model. We had to build the model in a vacuum without being able to discuss it openly with UVM. But once we were free to discuss it, I met with Todd Keating, my counterpart up there, the CFO of the Health Network, and he thought, frankly, it was actually a conservative assumption that we ought to be able to do even better. So he concurred.
So a lot of this savings is from that passive savings that I referred to?
Well, it's cascading, so
Yep.
it's the set of initiatives,
Right.
assuming we're still going to do some heavy lifting.
Yep.
But then we're going to achieve the free lunch
Okay.
on top of that.
Okay. And then this last graph is days cash on hand. That's how we measure our savings. And in 2021, we put the medical office building in here in all the models. So you'll see a drop in 21 in all these models. But you'll see our days cash, independence kicking along, getting down into the danger zone here. Going forward independently and being ambitious, a little bit better, but still not great, and then the UVM model looks better. So the financial modeling we've done supports affiliation. Yes, Max?
Max Kraus again, sorry for so many questions, but will you...
You only get 3. That's it. Make it a good one.
Okay. Will you have the opportunity to develop a joint budget with UVM before you sign up? I hear that we've made a lot of assumptions that
Yeah.
they say, well,
Yeah.
probably do even better than that.
Right.
But it seems to me it would be very important to be able to get to the granular level
Right.
and say, if we are going to join,
Right.
this is what our joint goal will be,
Yeah.
and we both sign off on it.
I think that's a great point. Clearly, if we go this road, we're going to spend the fall and the winter digging into the details. But actually, as I think about this, if we were to go the road of affiliation, we'd probably sign a term sheet, letter of intent, in October, let's say, for instance. So the due diligence would be taking place through the fall and into the winter, and we start our budget process in February. So we might be starting our budget process before we would sign any sort of definitive agreement. So that may line up nicely for that sort of conversation. You know, we've talked a little bit about that statement, that UVM would approve our budget, and Steve, our CFO, has talked with their CFO, and sort of our vision is that they would give us budget targets. They would say, you need a margin of 2.5%, and you need to generate 5 days cash on hand. Have at it. That's our assumption, but I think it'd be nice to know that that's really the sort of approach they would take, as opposed to a line item veto approach where, you know, they give us no guidelines, we come up with a budget and they say, no, cut this, cut that, you know, specific items. The guideline approach is what they've been doing with Central Vermont?
That's correct.
Yeah.
Not only with Central Vermont, but with Plattsburgh and the others in their system. I think it's important to know that they've already been working with us on some cost savings. We have one vendor who, just based on their sponsorship, their recommendation with no strings, has already allowed us to enjoy their level of tier pricing for medical supplies. That's allowed us to save annually $100,000 just from one contract. That's already happened with no strings, and so we've already started to work collaboratively with them. Some other opportunities, like Fred listed insurance and so on, they do their malpractice through we buy premium insurance. So, right off the bat, you switch malpractice over and there's a substantial savings. Some of those things really are a bit of a free lunch. So I think we'd be able to get our arms around that probably within the next 3 to 4 months.
Yeah. Yes.
Changing from budgets to
Yeah.
patients.
Yes.
We came to Vermont with an insurance, a private insurance company.
Yes.
That was not accepted by Porter.
Okay.
UVM does.
Really?
Happens to be a New York State system.
Yes.
Does that mean that an affiliation would provide patients with greater insurance?
Well, that's a great question. So the question was, tell me your name?
Pat Anderson.
Pat Anderson from Cornwall. Okay. So Pat's asking, moved to Vermont with an insurance company that we happen not to take, but UVM does. Is that sort of the issue that we've talked about around contractuals?
Yeah, won't happen on day one, but they will assist us in assessing all of our current contracts, and they will, as contracts come up for renewal, they will negotiate to include Porter in their negotiations.
Right.
We have a number of commercial insurers that either we don't contract with, or if we do contract with, our deal may not be the best, but they only represent maybe 0.5% of our total book of business, so it's just not relevant. Whereas up there, even if it is only 0.5%, it's a much larger dollar value, of course, right? So.
And that includes participating physicians, the
yes.
$20 copay only kind of stuff.
Well,
would be
some of that is
for
driven
us,
by your own
Burlington,
personal
but not
needs.
here.
Right. That would be to come gradually over time, not on day one, but probably within 2 years. I think you'd start to see the benefit from that.
Okay.
Thank you.
Okay.
I have
Yes,
a
ma'am.
question
Yes.
about how big is Porter's budget compared
Yep.
to the other affiliates?
So our budget's approaching 90 million. UVM, what is it?
Is it 600?
How much?
Steve says 600.
600 million? And Central Vermont is,
I want to say 3x, so 180,000.
Yeah.
180 to 250, somewhere in that range.
Okay.
I'm not-
okay,
I'm basing
so we're
that just on
ballparking
their
it.
Bed size.
So they are that much bigger. I don't know anything about them.
Yes, I mean, yes, UVM provides half the healthcare in the state of Vermont. So,
I have a sense
yeah,
that
by dollars.
I have a sense that Plattsburgh is sort of similar to CVMC.
Right.
And then, of course, Elizabethtown is a critical access hospital that's actually smaller than us. So it runs the gamut.
Yeah. Lynn.
We get an enhanced
Lynn Larson.
treatment for being a critical access hospital, and we get to keep that?
Yes. So we stay our own independent entity. Critical access hospital, it's a a regulatory designation. You have to apply for it through the government, and once you get it, you get reimbursed better for lots of services. So it's in our best interest to stay at critical access hospital, and if we're a member of the UVM network, it's in their best interest for us to stay at critical access hospital so that there's more money coming into the network. So that would stay.
Again, by way of example,
Yeah.
Elizabethtown continues to be a critical access hospital under the UVM network, benefiting from critical access.
Yeah. Other questions? Other
All the
issues?
hospitals that they own, all the
So
vendors?
so UVM has Plattsburgh, E-Town. Now, Ty is, Moses Ludington is a subsidiary of Plattsburgh, correct? Do you know? Don't know. Okay. And then Central Vermont and Montpelier. Yeah.
Alice Hyde.
And Alice Hyde, right. Alice Hyde and Malone. Right. Okay.
And I believe there are conversations with the hospital in Potsdam as well.
Again, Potsdam. Yeah. Yes, ma'am.
Yeah, Bonnie Campbell, you kind of glossed over it, but that's
Yep.
because of the subject. You said something about we weren't able to update
Yes.
health records
Yeah.
because of...
Right. Not update the health records. So upgrade. So what we have a Meditech system. That's a good system. And every few years, actually every like 4 or 5 years, an upgrade comes along that makes it better, makes it easier for the doctors and nurses to use. And yeah, and it's a $3 or $4 million investment in this case. We were planning to do it in this coming fiscal year. We just really couldn't fit it in the budget, so we've kicked it down the road a year.
Right. But are we going to go through the same upheaval that we went through when you put the handwritten records into the computer?
Yeah. Not that bad. So I guess there's 2 scenarios. How's that?
Not an answer.
Yeah, I was here for that upheaval, and going from paper to your first electronic medical record is a huge upheaval. So we've crossed that bridge. There's 2 possible pathways. One is we stay independent, in which case in the next couple of years we need to do a Meditech upgrade. It's hard to know. The upgrade that we're contemplating, it's a big upgrade, so it would really change how things look and make it, again, easier for nurses and doctors to use the system. The downside is there would be some retraining, there would be some upheaval, but it wouldn't be cataclysmic upheaval. The other possibility is we go with UVM, in which case the good news is we get a better EHR and an EHR that integrates with UVM. The bad news is that would be a upheaval. Probably not quite the scale as going from paper to electronic. I think going from your first electronic record to your second, to your third, to your fourth is probably easier than going to your first. But going from Meditech to Epic would be a big project.
Are you going to take my PCP away for several days?
No.
Because before, it was like a week before I could see her again. Because she was off trying to learn these things that happen. And so that's not going to happen.
Keep in mind this is being recorded.
We will try and keep your doctor in the office.
And your phone number?
Right. Yeah, you know where I work.
All right, you'll do it.
Fred.
Fred Greenman, I think this is okay for this venue. How are you doing on hiring interns to replace those who have left and other doctors?
So
will this help if you did?
So I'll answer that in 2 parts. So recruiting is a cautiously optimistic story. We've hired 35 nurses since the first of the year, which is a lot of nurses. We're making progress there. We've hired, it sounds like about 8 physicians since the first of the year. 2 new internists coming to town. Coming to town, 1 in November, 1 in the first of the year. but we still have some more hiring to do. I mean, the good news is, back in March, April, it was a little scary. It was, it wasn't clear that when we went out recruiting, if folks were going to come. And what we're finding is that people want to come and work here and live here for the same reasons that we all want to work here and live here. And so we are making progress on recruiting. We have 2 internists coming. We have a PA going to AFM. Yeah, we've got a number of providers, mostly in primary care, coming. Our goal is to rebuild the Addison Family Medicine practice, which is our downtown practice, currently at 4 providers. Our plan is to rebuild that to 6, 7, or 8 providers. We're recruiting for Neshabie. We're recruiting for Bristol Internal Medicine. So we continue to recruit.
Do you think affiliation?
And that's the second part. We've done really remarkably well for years recruiting providers. I mean, I remember when we called them the Magnificent Seven. Dr. Koch, Dr. Fifield, Dr. Bryant, Dr. Eichner. There were 7 of them who were all retiring within a year, and it was total panic. And we recruited it and got folks, And then over the years, we've had other times when 2 or 3 providers have retired or moved on, and we've been able to replace folks. It's a great place to live. It's a great place to work. The college, we have more and more Middlebury College grads coming back. So, I'm cautious. At the annual meeting in March, I told people it would be 12 to 18 months to really rebuild and stabilize our primary care network, and I think we're right on track. Yeah. Other questions? That really is. I mean, that is the message we've gotten so loud and clear from the community. There just needs to be doctors in the offices. That is, and it's a need that we didn't used to fulfill. When I started here 25 years ago, we didn't employ any primary care docs, and it's a niche that we've come to fill since I've been here, and now that it's the expectation, and we need to fill that need. So, yeah, we're going to work on that. Okay. Thank you all. Thanks so much. Thank you. Great questions.